So I'm Dr. Benjamin Levy. I'm an associate professor at the Johns Hopkins Sidney Kimmel Cancer Center at Sibley Memorial Hospital in Washington, D.C. So there are now multiple frontline strategies for patients with advanced non-small cell lung cancer without a driver. We've had several new regimens added only in the past 6 months. So first, KEYNOTE-024, pembrolizumab compared to chemotherapy for PD-L1 greater than 50%, independent of histology, and that trial showed an improvement in survival, leading to the approval of pembrolizumab for a PD-L1 cutoff of greater than 50% for advanced stage patients, irrespective of histology. KEYNOTE-042 was the next study that was presented, and that's using a cutoff of 1% rather than 50%. Very similar design as KEYNOTE-024, and that trial also showed a benefit in survival with single agent pembrolizumab versus chemotherapy. However, in the 1 to 49 subset, which was an exploratory subset, there wasn't a benefit, and I would make the argument, while pembrolizumab is approved greater than 1%, we should only use it greater than 50% based on the 024 data. We then, and sticking to the theme of single agent immunotherapy versus chemotherapy, more recently the Empower 110 trial, which compared atezolizumab, a PD-L1 drug, versus chemotherapy, showing in the IC3-TC3, that's a different biomarker for PD-L1, but showed an improvement in survival. And in a retrospective analysis using the PD-L1 platform that was used from the KEYNOTE trial of 50%, there was also a survival advantage. So based on that, atezolizumab is also approved in this setting. Of course, there's KEYNOTE-189. That is a trial specifically in the non-squamous patient population comparing carboplatin pemetrexed pembrolizumab versus carboplatin pemetrexed alone. Maintenance was allowed. And I think we all know this trial was published in the New England Journal of Medicine. The addition of pembrolizumab to chemotherapy showed an improvement in survival in the non-squamous patients, independent of PD-L1, including PD-L1 zeros. That's very important. PD-L1 zero patients do derive with the addition of pembrolizumab to chemotherapy. We have the Empower 150 data. That's carboplatin paclitaxel bevacizumab atezolizumab versus carboplatin paclitaxel bevacizumab for adenocarcinoma BEV-eligible patients. And that trial also showed an improvement in survival with the addition of atezolizumab to carboplatin paclitaxel bevacizumab, independent of PD-L1. Interestingly, subsets from that data, from that trial, looking at the EGFR subset, there were patients that had EGFR mutations that were allowed in the study. That did show an improvement in survival in that subset, and that makes us think maybe this regimen is appropriate for patients that are EGFR positive who are having disease progression on a TKI. Specifically in the squamous cell patient population, KEYNOTE-407, which was carboplatin taxane versus carboplatin taxane pembrolizumab. And that trial in a squamous cell population, independent of PD-L1, similar to the 189 trial in adeno, showed a benefit by adding pembrolizumab to carboplatin Taxol. Empower 130, another trial that went under the radar, but all of these trials, by the way, have approved regimens, led to FDA-approved regimens. So Empower 130 went under the radar, but a trial specifically in the adenocarcinoma patient population looking at carboplatin nab-paclitaxel atezolizumab versus carboplatin nab-paclitaxel. Nab-paclitaxel, not a drug we generally use in adenocarcinoma, but maybe a regimen to consider for our renal insufficiency patients that can't get pemetrexed. But this trial, again, showed that the addition of atezolizumab to carboplatin nab-paclitaxel showed an improvement in survival, and this regimen is approved. 2 final studies presented at ASCO leading to FDA approvals. One is Checkmate 227. This is a trial that's been published in the New England Journal of Medicine a couple of times and have an updated ASCO 2020, looking at nivolumab plus ipilimumab versus chemotherapy, specifically in the PD-L1 subset greater than 1. And this trial also showed a benefit in survival with dual checkpoint blockade with nivo-ipi versus chemo, independent of histology, but restricted. The survival advantage restricted for the FDA approval for a PD-L1 greater than 1%. Finally, Checkmate 9LA, which is a trial comparing platinum doublet with nivolumab, ipilimumab. So 2 cycles of platinum doublet with nivolumab plus ipilimumab, with continuation of nivolumab, ipilimumab, again, versus chemotherapy. And that trial also showed a benefit in survival independent of histology and independent of PD-L1. I can't believe there's this many regimens. Every regimen that I just went over is FDA approved. Unfortunately, we have not been able to compare any of these regimens head to head. All of these trials showed an improvement over chemotherapy as the control arm. So the jury is still out on some of these regimens, what the optimal regimen is. Is it nivolumab plus ipilimumab, or is it carboplatin, pemetrexed, pembrolizumab? I don't think we know. Hopefully, future trials will be designed to compare these approved regimens so that we can get answers for our patients.